Hello, everybody. My name is Alexander Zabok. I'm an anesthesiologist from Münster in Germany, and I'm supposed to talk about measures to prevent acute kidney injury. Here you see my disclosures. In the last couple of years, several experimental studies demonstrated that we can use different drugs to prevent or treat acute kidney injury. However, none of the drugs have been proven to be effective in the clinical setting, so there is currently no specific therapy available. AKI is a syndrome that usually occurs in the presence of other acute illness such as sepsis or heart failure. The pathophysiology of AKI depends on the underlying disease or cause. That means that the pathophysiology of contrast-induced acute kidney injury is different from the pathophysiology of, for example, sepsis-induced acute kidney injury. Acute kidney injury is similar to other syndromes in the ICU, for example, ARDS and sepsis. Almost 20 years ago, the Surviving Sepsis Campaign guidelines were published the first time. They were revised a couple of times in the meantime, and the guidelines recommend to implement different measures in septic patients, and these measures are supportive measures. And it has been shown that the implementation of this sepsis bundle improves patients' outcome, as shown in this study which was performed in China. So the implementation of the sepsis guidelines, the sepsis bundle in septic patient reduced the mortality, the in-hospital mortality from 45% to 31%. This is another study showing exactly the same. Here, the authors distinguish between the resuscitation bundle, which has to be implemented within the first 6 hours, and the management bundle. And they demonstrated that in the group with a high compliance rate to this resuscitation bundle, the mortality rate could be reduced from 39% to 29%. And for the management bundle, they showed exactly the same. In the high compliance group, the hospital mortality was significantly reduced from 34% to 32%. So the compliance with bundle improves patients' outcome. However, the compliance with the bundle is not always so easy, as shown in this observational trial, which was performed in France. The aim was to evaluate the compliance with a bundle of 13 ICU guidelines. And here on the right side, you see the different guidelines. Overall, they included 625 patients in this observational study, and they demonstrated that only 34% of septic patients were treated according to the sepsis guidelines. So only 34% of the patients received the sepsis bundle. Now you can argue the sepsis bundle consists of different measures, and it's really complicated to implement this bundle. But if you look for the ventilator setting, you see that only 37% of the ventilated patients received a low tidal volume ventilation. And here on the right side, you see that if you only have to implement 1 or 2 bundles per patient, then the compliance rate is quite high, up to 70%. But if you have to implement more than the 3 guidelines, then the compliance rate goes down and it's below 10%. In 2012, the KDIGO guidelines were published, and the guidelines recommend to implement a bundle of, which consists of different measures. And this bundle should be implemented in high-risk patients, and these patients can be identified by using biomarkers. And the bundle consists of discontinue all nephrotoxic agents when possible, ensure volume status and perfusion pressure, consider functional hemodynamic monitoring, monitor serum creatinine and urine output, avoid hypoglycemia, and consider alternatives to radio contrast procedure. And we wanted to know whether the implementation of the KDIGO bundle in high-risk patient identified by biomarkers can reduce the occurrence of acute kidney injury after cardiac surgery. And we performed the PREVACI trial in Münster from September 2014 to January 2016. Here you see the study flow. So we measured the biomarkers TIM2 and IGFBP7 in every patient undergoing cardiac surgery, and high-risk patient were were defined as a biomarker level equal to or higher than 0.3. And these patients were randomized into a control group. Here, the patient received the standard of care therapy. We only kept the mean arterial pressure above 65 and the central venous pressure between 8 and 10 millimeter of mercury. And in the intervention group, we implemented the KDIGO bundle. So we discontinue all nephrotoxic agents, optimize the hemodynamic situation. I show you the algorithm on the next slide. Monitor serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radio contrast procedure. Here you see the hemodynamic algorithm. First of all, we looked for the volume status. If the stroke volume variation was too high, we gave volume, mainly crystalloids. Then we looked for the cardiac index. If this was too low, we gave positive inotropes, mainly dobutamine. And in the last step, we looked for the mean arterial pressure. If this was too low, we gave vasopressors. We checked the algorithm every 3 hours, up to 12 hours. If we achieved the goal, that was fine. If not, we started from scratch. Here you see that we screened 882 patients. 606 had to be excluded because almost 500 patients were not at high risk, so they had a low biomarker level, and 106 patients had to be excluded because they met an exclusion criteria. So we randomized 276 patients, 138 in each group. First of all, we looked for the performance of the biomarker, and here we demonstrated that 72% of the patient with a high biomarker level, that means a TIM2 and a high FBP7 level equal to or higher than 0.3, developed an acute kidney injury, but only 21% of the patient who had a low biomarker level. We calculated the negative predictive value. This was quite good. It was 79%, and the positive predictive value was 72%. Here you see the baseline and operative characteristics. It's a busy slide, so there were no differences between the groups. Here you see the measures during the intervention period. So more patients in the intervention period received positive inotropes, mainly dobutamine, 30% in the intervention group and only 10% in the control group. Less patients in the intervention group received ACE inhibitors and ARBs, and the incidence of hyperglycemia was significantly lower in the intervention group compared to the control group. The implementation of the KDIGO bundle in high-risk patients undergoing cardiac surgery significantly reduced the occurrence of AKI after this procedure. If you look at all AKIs, this was reduced from 72% to 55%. If you only look for moderate and severe AKI, this was also reduced from 45% to 30%. Dan Engelman and colleagues published the data of a quality initiative program, and they measured the biomarkers TIM2 and IGFBP7 12 hours after cardiac surgery, so on the next morning. And once the biomarkers were elevated higher than 0.3, they implemented the KDIGO bundle, and they demonstrated exactly the same, but they only looked for moderate and severe AKI. This was also significantly reduced in the group in which was at high risk and received the KDIGO bundle. Now we first of all looked for cardiac surgery patients. Everything is standardized in these patients, but this is another study which was also published a couple of years ago, and here the authors used the same approach. So they identified high-risk patients by using biomarkers, but they didn't look for cardiac surgery patients. They looked for patients undergoing major abdominal surgery. They randomized 121 patients. As I said, they used the same approach. They used TIM2 and IGFBP7 to identify high-risk patients, and they randomized them into the control groups. They received the standard of care therapy and into an intervention group. Here they received more fluids based on the CVP, and they consulted a nephrologist, and he or she was supposed to maintain the perfusion pressure and discontinue all nephrotoxic agents. So the primary outcome was AKI within the first 7 days, and the authors demonstrated that the implementation of the KDIGO bundle significantly reduced the occurrence of AKI, as you can see here on the left side, and this was associated with a shorter ICU and hospital length of stay, as you can see here in this table. When we first published our paper, everybody told me that every patient gets a KDIGO bundle, and we couldn't believe this. And that's the reason why we performed a multi-center observational trial, and we wanted to know how many patients receive the full bundle. As you can see here, 37% of the patient receives 3 measures, and 26% receive 4 measures. But only 5% of all patients receive the full bundle. And we combined this with an interventional trial. This was a feasibility trial. The primary endpoint was compliance rate. That means the percentage of patients who were treated according to the KDIGO guidelines. Secondary endpoints were occurrence of moderate and severe AKI. As I said, this was a feasibility study. We recruited 280 patients. This was a multi-center trial. We performed this trial in 13 centers in Europe. And here you see that more patients received the full bundle in the intervention group compared to the control group. And this was associated with a significantly reduced rate of moderate and severe AKI within 72 hours after cardiac surgery. So let me summarize my talk. AKI is a syndrome that there will be no magic bullet that cures all cases of AKI because the pathophysiology is so different. Implementation of the bundles improve patients' outcome. Compliance rate with bundles is low. Educational programs have to be implemented to increase compliance rate. Thank you very much for your attention.